Good evening to everybody, and thank you for coming in this bad weather. I didn't expect even this audience to be here today. And first of all, I would like to tell you that the topic that came in the newsletter was functional appliances, but I thought it's more appropriate for a mixed audience to talk about interceptive orthodontics and then to go into functionals as a part of it. So I will still cover functional appliances, but with a bit of more detail, which would be more appropriate for this audience also. Well, if you see a boy like this is post-pubertal, about 16-year-old, class 2 division 1 malocclusion, fully established, and this doesn't fall into the category of interceptive orthodontics. This is comprehensive treatment. Now we have established malocclusion, and we would draw up our treatment plan and would treat this patient accordingly. Now, but if you see a child like this who comes to you around the age of 9 years, this is different. You wouldn't want to keep this patient for a later stage. Why do we say this? If you just look at this arrow, what you see here is recession of the lower incisor here. Now, this is essentially what a crossbite with a displacement would do, and the moment you see this, you don't want to keep this child for a longer time. You want to treat this with a simple removable appliance, and it's a very straightforward thing, and I'm sure all of us in this audience knows to treat this. What we do is just give a simple removable appliance with a Z spring on the tooth with a bite plane to disocclude the teeth, and this tooth can be corrected in less than 3 months into a proper normal position, so that the gingiva can actually grow back to its normal position. So this falls into the category of interceptive orthodontics. But if you don't do that, this is where you might end up. If you see, this is a fully established malocclusion, lingually placed lateral incisors, and the canines have actually drifted into the position of the lateral incisors, and now this is a fully established malocclusion where you need to extract teeth and go in for treatment. So it's always easier whenever you see a case which needs interceptive attention to address straight away, so that you don't complicate matters. So with that, the definition of interceptive orthodontics is to correct a certain obvious malocclusion, like what we saw earlier, or to prevent a malocclusion getting worse. So either of these situations, interceptive orthodontics comes into play, so that you actually provide justice to the patient at an early stage. So if you were to just go to the indications of interceptive orthodontics, simple crossbites with displacement, as I told you, we will come into details of all these slowly. And habits, as we know, we don't want to just keep them for a long time with habits. And if ever we see supernumerary teeth, erupted or unerupted depending on the situation, and retained deciduous teeth, accordingly we will have to deal with them. And overjets, which is more than 10 millimeters, and more importantly when they are unsupported. Now there's literature to say pros and cons of these. I will come to that also, but unsupported incisors is when there is a lip trap and the two incisors are completely out, lying on the lower lip. And median diastemas which are not physiological, we will try and identify how you can sort of identify a physiological median diastema. And then class 3 malocclusions, of course, you have to treat at an early stage if you were to do something. I will come to that also. And then, of course, obviously syndromes and cleft lip and palate patients. Well, before coming to interceptive orthodontics, why do we sort of talk of the ideal time to carry out orthodontic treatment? Because the growth is almost complete around the age of 11 to 14, depends on whether you're a girl or a boy. Mostly in girls it's around 11-12 years, you have slightly earlier puberty than boys, and then during that time the malocclusion is also established to a great extent. So you can assess and give the child a comprehensive treatment plan, and then all the teeth in front of the sixers are erupted, so it's a very accurate thing. And the compliance, because in a child whatever you try to do, it's very difficult to internally motivate a patient when the child is small, and then as the child grows on they become more conscious and aware of their malocclusion. So it's always easier, if you can delay treatment, it's always better to delay until you go into a comprehensive phase of treatment. And of course, leeway space is something that is very important, which might even convert an extraction case into a non-extraction case. So I will come to that also. So So basically, this is why we try to look at an optimal time for orthodontic treatment. So you look at basically the E space is something which is very crucial. So if you try to catch that time, it might really benefit the patient in a great sense. So I will not bore you with all these little things, but just to give you a few details. We all know in a primary dentition which is fully established, we would like to see upright teeth. That's what we normally see, with a little bit of spaces, and this is how a set of deciduous teeth would be. And then from there we all know that the permanent teeth come into play. So the spaces are being utilized for the upper incisors and the laterals because the teeth are much wider, and in the posteriors the leeway space. Same thing on the side, that's what we see in mixed dentition. And of course the leeway space, if you see here, this is the E space and that is the 5. So obviously you have space on either side, and this is what can actually make a difference if you catch the patient at a right time. So maybe at times, if you have seen the child around 10 years, if you still have the E's, and if it's a case where you can marginally manage, you might actually make use of the E space for treatment. So it's always best to catch them at that time. Of course, you need to do a OPJ and make sure they are there, and then to assess the position of the teeth before you take that decision. Now the commonest question, I answer this question even in odd places, not in the clinic, but this is a very common question where mothers are very worried. They would just come and show that my child has had a perfect set of baby teeth and now she's getting permanent teeth and they are crooked. What do we tell the patient? We just tell them, okay, this is a very normal thing, simply because the size of, now the child has started getting adult teeth, and the width of the adult tooth is that's the same as our teeth, but the jaw size is much smaller. So in theory what we say is, if we were to explain to this audience, what I would say is, it's up to 13 years the intercanine width keeps increasing. So because of that, this is called transient lower incisor crowding, which is because the mesiodistal width of the 4 incisors are the same as an adult, but the intercanine width is much smaller. So as time progresses up to 13 years, you try not to do anything with these teeth. You don't have to do anything because it will resolve spontaneously. This is called transient lower incisor crowding. So the message I want to convey here is, some of us try to still extract teeth for this, which is the last thing you want to do. I will slowly explain that. So this is another picture of the same thing. So this zigzag pattern is a very normal thing, and all you need to do to parents is to reassure and say, this is a perfectly normal thing, you don't have to do anything. Just keep observing. After some time, if it's necessary, when the jaws go up, if there is still crowding, then we will have to deal with that. Of course, when we see this is over-retained deciduous teeth. What we see here is another very common thing. What we see is the central incisors have erupted lingually. Now here, the moment you see this, we have to do something. What do we do? Now obviously the size of the central incisors are much bigger, but you only extract the A's and not the B's. Once again, because you have to understand, if you extract the B's, you are taking off you are trying to actually interfere with the intercanine width. So the basic fundamental rule is you only extract the predecessor and not any other tooth. So even if you feel there isn't enough space, there will be enough space. The moment you take out the A's, and the tongue will start pushing, and with the normal growth, there is a tendency that the crowding will resolve. By trying to resolve the crowding by taking the B's also off, you are going to create a primary lower incisor crowding into a secondary crowding, where you will have to treat at a later stage with extractions, and that's not what you should be doing. So here what we see is, once again, a number of baby teeth. So here, of course, you can easily extract this one, and this one here. But it's only a matter of deciding which teeth to extract, and C's is always a tooth that you have to be very cautious. You don't just take out teeth, because intercanine width, once again, as I told you, is maintained only when the C's are there. So unfortunately, we still have this problem of C's being extracted simply because the lower 4 incisors are crowded, and definitely that will cause a later crowding by making the canines erupt labially. If you do that, initially you solve the problem temporarily, but definitely at the age of 13 or 14, the canines will erupt labially, and you have to extract the force to correct that. So you are basically creating taking one malocclusion off and creating another one, which would have just resolved with the normal growth. So this is what I was trying to explain. Just because there is no space, this is the last thing you want to do. We don't extract the canines because that is going to be very detrimental. You just leave this and nothing will happen. The normal growth will take over and this crowding will resolve. So all you need is a simple assurance to the parents that this will resolve most probably. If it doesn't resolve after the age of 13, and that's when you start to assess and decide, and obviously this is a case of fixed appliances because you can't do anything with the removable in here, the lower arch. So lower incisor crowding will resolve spontaneously in most postnatal growth of the mandible. Do not extract both lower primary centrals and lateral incisors to relieve crowding of only central incisors. This is the take-home message of this. And do not extract the Cs to relieve crowding. These are basic rules in normal growth and development. So that's what we see. So the adverse effects of premature extraction of lower Cs. If you do that, the intercanine width is not maintained, and this leads to crowding of permanent canines which would need extraction of the first premolars later on for treatment. Unilateral extractions can cause shift of the midline, once again needing fixed appliance treatment later on if you were to correct the midline. And of course, unnecessary trauma to the child for something you really don't need to do. Of course, we all know the importance of baby teeth. So maintaining the leeway space is one important thing that we really need to concentrate on as dentists. This means actually, considerations is preventive measures is what you have to do, the basic standard things, and then a review once every 6 months. And what we should do is, if it's a class 2 cavity, what we should really do is to preserve if you want to preserve the leeway space, you need to do a proper filling with recontouring. Just a JIC will not take care of that. It has to be recontoured properly so that the leeway space is actually maintained in a class 2 filling. So this is something which is very crucial. And then we try to somehow, if ever there is caries even, we try to somehow preserve the, say for example D or E, the roots are very divergent, we know that. So even if the roots are there, if there is no pain, we try to still preserve the roots so that the leeway space is actually maintained. Provided the patient is symptomless, please leave the roots alone. So now we come to ugly duckling stage, which is another normal thing. And what do we see around the age of 8 years? You see a median diastema and then the lateral incisors going sideways, displaced, and we all know that this is normal. So just to explain to the patient that this is a very normal thing. The reason for this is actually the canines coming and touching on the roots of the lateral incisors. So this is causing this. But of course, at times, not all median diastemas are just physiological. So we have to be able to assess and see that there is no fibrous frenum. Whenever you see this, of course around the age of 8-9 years, if you see this, you don't do anything to this patient, but to just tell that there is a possibility that this may need surgical intervention later on. Of course, what we do is we keep the patient around up till about 11-12 years, and then you start treatment, and then you start closing the diastema. Halfway then you remove the fibrous frenum. So so that's how you do it. And the standard management is, if ever you see a fibrous frenum, it has to be always closed and then bonded on the inside also after the treatment, because whenever you do a fibrous, whenever there is a fibrous frenum, there is always a tendency that it can open up. So you have to be very conscious with this, but to make sure that you identify this, but not to treat too early also. And then to make sure that there are no supernumeraries, that's another cause for median diastemas. So you have to be able to make sure, eliminate other causes and say that this is just a normal median diastema. If you see something like that, of course, straight away you need to remove this and then close the gap also so that the laterals can come into the normal position. So always we need to take our upper standard occlusal if ever we suspect a supernumerary tooth, and then extract the erupted teeth. And decision of removal of unerupted teeth is very crucial, simply because it depends on the position of the teeth and more importantly the development of the central incisor roots. Because if you feel it's actually touching the roots and if it's going to damage the roots, you just leave it knowing that there is a diastema, knowing that there are unerupted supernumerary teeth. It's always a decision by the maxillofacial surgeon, because and then whenever the root is completed after about 9-10 years, that's when you take the decision to remove the supernumerary teeth. So knowing that, you might have to wait for some time. Now we come to habits. Now this is once again, thumb sucking is a very common problem. So what we do is, what we thought earlier was, okay, let the child be until the permanent teeth erupt, and if they stop at that stage, all right, the permanent teeth will come to its normal position. That was the idea that we had. But actually there's more literature coming up to say that after 3 years of age, if you suck your thumb, what happens is, if you stop that by the age of 6-7 years, the teeth will not be protruded, but the narrowing of the maxilla, which takes place by the negative pressure from the thumb, when you do that, the narrowing of the maxilla, which actually that does not reverse on its own. So what they actually recommend is, after 3.5 to 4 years, to try and discourage and stop the habit, not to wait till the permanent teeth erupt, because even though the teeth are in the right position, otherwise the rest of the things do not spontaneously correct. So we try to stop this at an early stage nowadays. And then hints in management of open bites due to thumb sucking. Discuss with the child and persuade the child to stop the habit. That's the first thing. We don't do any appliance, but try and have a little chat with the child. That's the most important thing, because this is a very sensitive issue, and there are studies showing from University of Alabama saying if you try to take this habit off, they get used to even worse habits. So because of that, you have to be very careful. This is something where you have to tackle very carefully. So allow the child to implement this for a few months also. We don't straight away do this and in a week you can't get them to stop it. So we have to be very slow in this. We have to be very patient, and then with the consent of the child. And if it's not successful, only once again with the consent of the child, you can show the child what's going to happen and then explain to the child, and then slowly start on a habit breaking device. So the device will depend on, the type of device will depend on the degree of the problem. If there is a crossbite, you might have to have an expander also in this. I of course personally prefer fixed devices, simply because fixed tongue guard, simply because if you have a removable tongue guard, it could work, but they can always take it off and put the finger in. So I have basically given up on removable tongue guards for all practical purposes now, and it works very well with a fixed one, because whatever they want to do, they can't take it off. But before doing this, there is one more step where you can actually tell the patient, wrap, with the consent of the patient, the mother can actually wrap something, put a glove, and then even a soccer glove going up to this, and then all that you can try before you go into the appliance. And also if they're doing it mostly in the night, you can't stop it, but watching TV, that's a very common thing. So what we say is, okay, you have to tell the patient, if the child is going to do this, the TV goes off. That's the reminder. So you have to slowly start. If they fail all that, only they come to the stage of a device. We never give the device straight away. And the open bite will settle spontaneously when the habit stops. Habit stops in 3 to 4 days. They will have a bit of a disturbed sleep for about 3 to 4 days, and the habit stops. But we don't take the device off, simply because, one, the habit can go back. Two, the tongue is used to coming forwards, because tongue was actually accommodating the thumb. So the tongue takes a much longer time. So a minimum time frame that we give is actually 6 months. And also if there is constriction, to expand it and allow the bone to form in the mid-palatal suture. So all that takes time. So the standard time frame that we talk of is usually 6 months for this entire thing. And we don't do any active treatment. What I mean by active treatment is retracting the teeth from where it was during this phase. We only treat the open bite and leave it, take the incisors to where they were, and then take it on from there. So never start active treatment while the habit is on, because there will be contradictory forces acting on the roots of the teeth. We are trying to push the teeth back, the child is trying to bring the teeth forward, so there is forces acting on the roots, and that's going to be bad. So we never do this. So this is just a pair of twins who had the same open bite, and this is simply with the device, nothing else. So we've not done any active treatment. Of course we had to do active treatment from this point onwards, but then this is simply with the RME and the tongue guard that they have got into almost a normal position. Right, so from there we come to this. This is a very common thing that we see. This is what we refer to as unsupported incisors. So the child comes like as if the two incisors are completely out. So basically there are two schools of thought in this once again. So whenever you see this, the child is also to a certain extent psychologically affected. That's one thing I check all the time. But once again, the literature that we have says even if there is a psychological impact on the child, that actually gets back to normal when they're slightly older. So psychological impact is also something which has now been removed. It's not 100% cost to treat also. So the options when we see a child like this, I of course do this very simple thing. I just give a simple screw plate. I do this very often with of course the dimensions, the vertical dimensions have to be normal to do this. Flat anterior biplane with a midline expansion screw and a reverse loop labial bow. The reverse loop labial bow actually is much longer than the U-loop, so it exerts a very ultralight force on the incisors and it nicely tucks. All what you are trying to do is to simply get the incisors to go back behind the lower lip so that the lip is covering the teeth, so that the malocclusion does not get worse until the patient is ready for comprehensive treatment. That's all what you are trying to achieve. This is not a complete treatment. So this is only an interceptive method. Of course, if the patient is a high angle where you can't put a biplane, we just go in for 4 brackets on the 4 front teeth, which we refer to as Parkmans, with a headgear. High pull headgear will actually bring the mandible forward. That's the ideal treatment. Of course, the ideal treatment is not very compliant by most patients, so this is why we try to give a simple removable appliance to most patients, which is a lot more user friendly. And of course, functional appliances is another option where you can consider at this age. Of course, you have to weigh the pros and cons of this. We will come to that. If you don't treat that at the age of 6, 7, 8 years, this is what will happen. This is the typical idiotic look of this child, because the child now gets bullied in class and it's going to be a psychological trauma to the child, and this is not what you want to give the child. So basically this is why we treat these children early, to prevent this from happening. What has happened is the 2 central incisors were out, it was not treated, it kept coming forwards and the lip kept pushing, and all 4 incisors are now out. So functional appliances, these are all the types of removable functional appliances we have. We are all very familiar with twin block. I think I'm also a firm favorite of the twin block. It's actually much easier because it's in 2 parts and the patient finds it a lot more comfortable and user friendly than the other bionator and these other monoblock types. So this one is actually quite a comfortable one if you were to use a functional appliance. We will come to the use of functional appliances, but that's a removable one. But if you see this child is slightly older and of course with a very big overjet of about more than 10 millimeters, here what we have done is gone in for a fixed functional appliance, because with a functional appliance the effect that you have has to be constant, but a fixed functional appliance will give you a very constant heavy force. So this is a fixed functional appliance. And then of course we have not extracted teeth apart from one lower central incisor which was completely out of the arch, and that's without extracting the upper teeth at all. So this was actually aided with the fixed functional appliance. Perhaps the removable may have not gone this far, but just to tell you that functional appliances can actually be very effective also. Knowing that, we have a lot of randomized clinical trials coming up about functional appliances. These were all done in the late 2000s, 2006-7 years. They all started coming out, the literature. Now from all these universities, the last one, University of Manchester, was a multi-center clinical trial, and all the studies, because functional appliance was used very comprehensively that time, and then what they did was to have a group of about 9-10 years and gave functional appliances, and the other group they left till about 13-14 and they went in for comprehensive orthodontic treatment. So one group had functional appliances and comprehensive treatment, the other group had just comprehensive treatment later on. So it was 1-stage versus 2-stage treatment, and all these studies came up with the conclusion that there was no difference between the two. So basically giving a functional appliance earlier did not have much of a benefit. So I think what they said was basically the mandible grows, and we think that it's actually we grow the mandible, which doesn't happen that way. It's the normal growth of the mandible. If you catch the right age, in a normal grower, what happens is you are achieving something today which you would have anyway achieved tomorrow with the normal growth. So functional appliances is something which is actually in a gray area nowadays, simply because the literature, the evidence that we have really doesn't suggest 2-stage treatment, because you can do the same thing with a comprehensive treatment. Doesn't mean that we don't use functional appliances. So indications of functional appliances, especially in our setup, we can't be giving fixed appliances to all patients, especially in the government sector. Even otherwise it's not easy. So class 2 division on malocclusions with a retrusive mandible. With retrusive mandible is, I will come to that with a picture later on, but the mandible is relatively behind and the maxilla is in a normal position. So actually trying to, which is the normal growth of the mandible of course, which will happen anyway, so you are trying to just advance that a little bit. And the lower incisors have to be retroclined or upright, simply because lower functional appliances will definitely bring the lower incisors forward. So if it's a case where it's desirable for the lower incisor to come forward, so that's only when they're retroclined or upright, then you decide on a functional appliance, and there should not be any form of crowding. So the arches have to be well aligned so that you really don't go into a second phase of treatment. If you are going into a second phase of treatment, functionals wouldn't probably help so much. And the upper incisors have to be proclined, because the effect of a functional is uppers go back, the lowers come forward. It's the teeth that move, it's not the jaws or the mandible that actually change its position. And of course the patient has to be around the pubertal growth spurt. So then it's very effective. As I told you, what nature would have done anyway tomorrow, we have done today, and we probably try to get credit for it. Advantages: it's very cost effective compared to comprehensive treatment. Quick response if the child is compliant. It's very effective. 9 months you can get a really good result and could eliminate the need for extractions. I showed you the case earlier. At times a non-extraction case can be converted to a non-extraction with this, and less chairside time. Disadvantages are the patient compliance. This is patient compliance dependent. If the child doesn't bite, nothing happens unless you give a fixed functional. And the lower incisors are pushed forward to such an extent that actually you can, if you have not done a proper case selection, a non-extraction case automatically becomes an extraction case at the comprehensive phase of treatment. This is what I told you, because the lower incisors are brought forwards to an extent that you need to take them back once again, and there is no space because the entire arch has come forwards. So you need to extract teeth and pull them back. So this is not what you want out of functional appliances. So case selection, try and select a case where the lower incisors are retroclined or upright. So then that's very effective. And of course growth dependent and may need a second phase of treatment, which will make the treatment much longer. So the patient actually, the compliance becomes very poor when it goes into 2 stages and when you have to have the treatment for about 3-4 years. Because when you can just simply treat it in 1.5 years. So the facial evaluation, let's look at this face. What we see is the maxillary teeth, the maxillary bone here, the mandibular teeth and the mandibular bone. So well aligned, this, let's assume a balanced face. And what can happen is, if your maxilla is protrusive like this and the mandible is retrusive, that's the maxillary teeth, these are the mandibular teeth, but if you see the jaw bones are still in the same position, what should happen? They should go in that direction and the teeth should come like that. And here what has happened? What has actually happened is your mandible is behind. So, and the maxilla, the mandible and the teeth are retro position. So what you should ideally do is this, which is a very non-compliant appliance of course. When you do this, that's a headgear, you take this, and as a side effect, the mandible has to grow. This is what we try to achieve with a functional appliance. This is exactly what happens with a functional appliance also. But in a functional appliance, the lower incisors come forwards, whereas in this the lower incisors are not affected. This is the advantage of this. So this is called the mandibular autorotation, which takes place by the maxillary retraction. So this is the ideal thing, but a functional does something very similar, of course with the side effect of the mandibular teeth being proclined. So these are the devices that you have for that. So just a bit about functional appliance. What you should know is, yes, functionals still have a role to play, and then do a proper case selection. If you think the patient doesn't need a second phase of treatment, go in for a functional appliance. Let the arches be well aligned. Simply go in for a functional appliance. That alone can be the treatment of choice for that patient. It's fully worth it. But if you think there is crowding, don't just go in for a functional and make matters more complicated. It's only going to complicate the entire problem and perhaps go in for extractions which may not even need extractions. And it's unfair by the patient going in for 2 phases, a very long treatment time as well as the cost. So if you see a child like this, what we see is a negative bite. So this is obviously a class 3. these are cases where interceptive management is essential, because whatever we do, you have to do it at a very young age. What the literature says is the mid-palatal suture up to about 12-13 years you can split this apart, and all the bones in the facial area. So what we do is we give a rapid maxillary expander and sort of loosen the entire segment in here, and then with the face mask we pull it forwards. And the effectiveness of this happening now, there's a side effect on the teeth come forward, that's not what we want. We are trying to get an effect on the entire facial skeleton, the mid-face deficiency in here. So if you want more of a skeletal change, you need to do this around the age of 10-11 years, or even slightly younger than that for girls. That's the most effective age, and that's worldwide documented. This is contrary to functional appliances. This is documented that actually if you do a face mask to the maxilla, the growth that you gain is beneficial, and that's going to retain, which may not happen otherwise. But for functionals, what we said was the growth would have anyway happened, we are just trying to do this. But in a face mask, in a class 3, the maxilla is not growing. So this aid of bringing it forwards, it may have grown just half a millimeter in that entire time frame, but this can go up to 2 to 3 millimeters, which is beneficial. So what I tell the patient is, of course, the mandibular growth is something which is beyond our control. Of course, there are devices like the chin cup, which is very cumbersome, and the literature that's available only comes from Japan, and you have to do it for a very long time. So basically we have more or less given up on controlling the mandibular growth. So whatever we do in a class 3 is only targeted on the maxilla. And then what we say is we take the maxilla to where it should be and we leave it there. Of course, the mandibular growth is something which is beyond our control. At the puberty growth spurt, if the child keeps growing and the mandibular growth continues, we cannot do anything. So what we what we give is a guarded prognosis. But by this procedure, you may convert a surgical case into a non-surgical case, or the complication of or the amount of discrepancy that's there at the age of surgery is definitely reduced. So this is a beneficial thing to do, face mask therapy, something that's recommended worldwide around the age of 11-12 years, and then you leave the patient, if you have missed that, leave the patient for surgery or then decide later on. So that's what we do. You have to direct it in such a way that there is minimal effects on the maxilla, but effects on the teeth, but only on the maxilla. The maxilla actually rotates clockwise if you don't do this properly. So the beneficial for maxillary retrognatism or mild mandibular prognatism. If it's a pure mandibular prognatism, this will not work. We are only trying to target on the maxilla. So if you think it's a lateral ceph, will tell you by certain analysis you can decide whether this is a pure maxillary prognatism or maxilla is involved. If it's pure maxillary mandibular prognatism, you can't do much about it. You just need to leave the patient. If it's in the maxilla or mild mandibular prognatism, you can certainly do this, but there is always an age limit to do this. If not, of course, you leave the patient for surgery later on. So coming to ugly duckling stage, why I had this was just to show you about the canines, because this is something which we can easily correct, and if we miss it, it might go a long way. So primary canines can get impacted, and palatal impactions are most of the time either it's not common, it's about 3% of the population, and what we see here is a canine that's actually going across and the C is retained. And then when that happens, you have to, if you don't catch this patient at the right age, you have to apply apply traction, pull this out, still you can get this out. It's a lot of work. And then going in for all these things, and it's not easy getting the canine, especially on the palatal side. Okay, so there's one easy thing that you can do. Simply refer the child around the age of 9 to confirm that everything is okay. So why do I say this? This is because at the age of 9 years, if you do a simple upper occlusal X-ray, what you should see is the canines like this. They should not be crossing the lateral incisor. Then the moment you see that, you need to take the upper C's off. Now I was talking about the lower canines and I said never to extract this. It's the contrary when it comes to the upper canines, because this can prevent a major malocclusion. So please don't mix this up. Lower canines, don't extract. Uppers, decide on a upper standard occlusal X-ray. Why do I say this? Now this is the evidence that's available. If you see this happening. Around the age of 9-10 years, the canine is inside, and that's where the C is, that's where the canine is meant to be, and the canine is actually going in an unfavorable direction, but still not crossed the midline of the lateral incisor here. Now if you extract this C at this point of time, the evidence is that this will spontaneously come down 91%. So it's just a simple matter of extracting the C's here. That will correct the problem 91% of the time. If you have missed that, still, if it has passed the lateral incisor, gone towards the central incisor, if you extract this, you still have a chance of 64% that the canine will spontaneously come back to this position. So you are providing a lot of justice to the patient by doing this if you catch this at the right time. If you don't catch this, this just continues and it goes in as an impacted canine, root resorption, exposure, traction, lots of things. So this is a very, very simple thing. That's the position. So if you see this, now this x-ray, what do we see? On this side, it's all right. It's simply a matter of taking this off, but you don't need to even take it off. But on this side, what you see is actually crossing. So you have to quickly take this canine off. That's what it says. So this has a 91% chance of spontaneous eruption. This girl actually, she had a canine. When she came to me, she has passed this age, she was 12 years, and then what we saw was that the canines were not there, and these were the x-rays. If you see on that side, that's just touching on the lateral incisor. Had we seen this around the age of 9 years, I would have simply taken both these. So on this side, there was a 91% chance of this coming into line. Here, there was at least 64% of chance of this coming into the spontaneous alignment had I seen this at the age of 9 years. But this was missed, and when I saw her, she was 12, and that's what we saw. Now this is at the central incisor level. Trust me, I'm still struggling. Dr. Jayatilaka knows this. We did the surgery 2 times. I'm still trying. One side the canine has dropped down, the other side after 2 years it's still trying to come down, the side where the canine has gone into the central incisor. It was a simple matter that was missed, and now it's gone to a stage where I'm really struggling to get that canine out. CBCT all done, there is nothing blocking this, but still it's just very resistant to coming down. So impacted canine, especially on the palatal side, is something which can easily be prevented, which needs to be attended at the right age. So labially displaced canines on the other side is mostly due to premature loss of primary teeth. Because that's the upper canine is the last one to come into the arch in front of the sixers. So all the other teeth will utilize the space that's available, and the last one to come out doesn't have space because the leeway space is not maintained. It will just come out labially. So that's what happens. So if you preserve the leeway space and utilize it properly, this problem would be solved. Same here. So preserve the leeway space and avoid extractions of deciduous teeth as much as possible. Eliminating buccal corridors. This is something that we see, especially if you have a thumb sucking habit. And then this, of course, I'm sorry, this is not clear because I just got this picture from the internet. But if you see, this is what's referred to as a dark buccal corridor. On the sides, when your maxilla is narrow, that's what you see on the sides here. But it's always much nicer when you have a wider smile. The buccal corridors have been eliminated. So if you see a patient like this, you can treat in either of this way. You can just treat this and still have the buccal corridors, or eliminate the buccal corridor. Of course, if this patient comes at the age of 20, I can't do this, because if I want to eliminate the buccal corridor here, you have to have a SAB surgery, which is definitely not worth just for that. But in a child, if you see the child around 10-11 years, there is definitely a way of doing it. You can certainly go in for a rapid maxillary expander, expand the mid-palestral suture, and then treat it. You can perhaps go in here. So that again is timing that you need to catch and do this properly. So that again, you don't wait for interceptive treatment, but you do that earlier and then leave the patient for the rest of the things later. Serial extractions still done in certain cases. You have to be very selective when it comes to serial extractions. You have to be very careful, but still, look here. This side is just blocked. You can take these two off. That has just dropped. You have not done any treatment. It's just a matter of timing, making sure, take an x-ray, make sure everything is fine, and then a decision making to make sure that you provide justice to the patient. So in this case, what do we see? This is a patient where there is severe crowding, and then that's the blood set. So class 1 type malocclusion, moderate to severe crowding, minimal overjet and overbite, and then all teeth present and skeletal, either it has to be a class 1 or mild class 3. So whenever you see this, and what you do is you take a OPG, also make sure all the teeth are there and they erupt in the normal sequence pattern. What you basically, just to remind you of what we do, basically what we do is extract the D's, allow the fours to come through, and then extract the 4s and allow the 3s to come through. That's what we do. So anyway, what we do is to extract the 4s, but here you do it well in advance so that you allow the 4s and then get the 4s and erupt the 4s so that the 3 comes to the right position. So whereby what we try to achieve is simply getting the malocclusion to sort on its own. So if you, either you may not need any form of orthodontic treatment, or even if you go in for comprehensive treatment, that's going to be a very short one for about 6 months, whereas otherwise you would struggle for 2 years or more. So it's just a matter of deciding on the time for that. And then these are special cases where this patient came with a very big swelling in here, and then when we examined, this is what we saw, the IOP, the occlusal, the OPG. So the canine was displayed. So these are things where you don't just keep, obviously, so these have to be treated. And class 2 division 2 at a developing stage is a very, very easy way to treat. Class 2 division 2 is a very complicated one where treatment you can do easily, but long-term retention is always a problem when it comes to class 2 division 2. It tends to relapse, not the overjet, the overbite. So what we do is, at a developing stage, you simply try to correct it, to bring it to a class 2 division 1. All of us as students, I think, have done this. Simply push the 4 incisors forwards, get it to a class 2 division 1, give a functional appliance, it all gets corrected. It's very easy. This is what you do when you, a case like this, procline the incisors, give a functional appliance, it will all get corrected spontaneously. Of course, in a slightly more complicated one, when there is crowding, you might, this is a device called a pendulum device. So I just thought I'll just show this, where it's actually trying to distalize the molars. You can do this before the 7th erupt. And see, we are short of space for canines here fully. Now the drawback of this device is that it actually dumps the incisors forwards. Well, in a class 2 division 2, that's what you want. You make use of the side effect, and what you have done is you have got this much space by distalizing the molars. You've got one premolar space fully, and the incisors have proclined, and that's what we want in a class 2 division 2. So we nicely align the teeth, the crowding is relieved. So this is case selection and management which is done in these patients. So of course, missing lateral incisors, what we do is we just close the diastema. When there is a missing lateral, always there is a big diastema. We close the diastema and leave the patient for some time, wait the canines to erupt, and then decide rest of the occlusion. If there is crowding, we make use of the lateral incisor space that was utilized to relieve the crowding. If not, we have to open up space for 2 lateral incisors. That's a decision which might have to be taken later on. And then this boy, of course, this kind of cases, the moment you see, you treat them. That was this tooth is dilacerated. So, but we are still trying to pull it out. We did a CT and it was dilacerated, but then it's nicely coming down now. So you have to intervene these patients early and treat accordingly. As the last one, traumatized and submerged teeth. This is not done so much in Sri Lanka, but if you have a traumatized tooth, you don't have much of an option in a growing child. If the tooth is submerging, according to Anderson, the only method available is auto-transplant. What you do is, because if you leave this, the tooth gets submerged, so the gingival margins will never be right because of the normal vertical growth of a developed growing child. So you have to do something, you have to remove the tooth. The moment you remove the tooth, the bone gets lost. So because of that, you need to do an auto-transplant and rectify the problem. So that's what we have done here. If you see, this premolar has been taken and auto-transplanted as the central incisor position. Of course, there is a direction in which you do it, and then you trim off the rest of it after the RCT, and that's where. So here the gum margin will stop here growing. Even now there is a difference, but had you left it for much longer, the gum margin would be way above, and that can never be corrected. So if it's submerging in a growing child, you don't have much of an option but to go in for this. Another one, both the incisors, if you look at this level, incisor, the gum margins, they've gone up a fair bit by now also. So you stop it at that by doing this, and that's what you do. So in summary, extremely important to preserve the primary dentition, and extraction of deciduous teeth should be performed only in specific situations. Extracting lower primary incisors to relieve crowding will only worsen the condition. Interceptive orthodontics in suitable conditions will definitely benefit the patient long term. Since my topic initially was functional appliances, I would like to answer any question you have with regards to functional appliances if you think I missed on something.